I feel a little bit out of place because I am not a heart failure specialist, but I'm doing my best to learn and learn quickly, because for the last 5 years it's become obvious to me that heart failure is the epicenter of the future of cardiovascular medicine. That everything that we do ends up with heart failure. Whether it's cardiomyopathy or ischemic heart disease or valvular heart disease or rhythm disturbances, heart failure is the final common pathway. So we have to focus our attention at being able to manage heart failure, and we believe that there's a role for complementary transcatheter medtech approaches with this advancing, very formidable pharmacology. So I'm going to try to give you at least some of our perspectives, and I'll go very quickly, but give you a very broad sense as to how many things are being tried now in the heart failure space that are more device-related. We became interested in this several years ago when we developed a meeting called THT, which was Technology and Heart Failure Therapeutics. It was led by a very close personal friend of mine, Dan Burkhoff, who's one of the key physicians, who's a heart failure physician but understands hemodynamics and is very device-oriented. I'm going to try to divide this up in a very organized way. I want to give you some general concepts and the rationale for using devices in heart failure, and then to give you a whole series of scenarios that are now so-called hot topics in heart failure that cross over to device-based approaches, including cardiogenic shock, the use of intra-atrial shunt devices, remote monitoring strategies, acute decompensated heart failure for decongestion therapies, and then LV remodeling approaches. And I'll do this very quickly, but give you at least an overview of the breadth of what we're trying to do to, again, complement what our colleagues are doing on the pharmacology side. So some general concepts. I've been taught that heart failure is a chronic systemic disease. There are many cardiac, hemodynamic, neuroendocrine, and inflammatory therapeutic targets, and you see the host of different organs that are affected by heart failure therapy. There is no question that over the last 5 to 10 years that the new, what I call super pharmacology, has had a huge impact in managing patients, particularly with heart failure and reduced ejection fraction. So now we have the multiple pillar concept, and you've already heard a beautiful lecture on how ARNIs are being used, integrated. SGLT2 inhibitors are now very big in the United States as well. So there are many new drugs in heart failure that certainly are having an effect. But the reality is there's still a significant residual risk, that's an important phrase, of events in advanced heart failure, despite optimal medical therapy. So this is from a landmark study. This is the control arm of the COAP trial, which is a study looking at inpatients with optimal medical therapy who were randomized to mitral TEER. And this is the control group, and you can see the event rate, despite optimal medical therapy, was extremely high. And if you look at other studies, like the control groups of GUIDE-HF, irrespective of the heart failure category, whether it's HFpEF or moderately reduced EF or HFrEF, still very high residual risk of events in advanced heart failure just with GDMT. Although interestingly, the Momentum 3 trial, a pivotal study looking at LVADs in even more advanced heart failure, are now beginning to show some stability of both the composite endpoint and the overall survival. And this is as destination therapy. So we think there's a therapeutic gap that remains in the treatment of HFrEF. Certainly, what you've just seen with pharmacology, extremely effective. But as the disease progresses, before you're dealing with a situation where you require LVAD and transplant, there is a therapeutic gap. And that therapeutic gap is now being filled by a variety of devices. You've heard mitral TEER 1 and several others that we'll be talking about. Now, even with some of these devices, we think there's still a significant residual risk of events in advanced heart failure. So despite mitral TEER as the treatment arm in the COAP trial, the device group, even though it was better than the control arm, was still not very good. There was still high event rates, and this is only at 2 years. At 5 years, it's much worse. Same thing when you look at pressure monitoring in the GUIDE-HF study, we see there's a very significant residual risk of events even in the treatment group, which basically says it's not good enough. Whatever we're doing currently with devices may be a little bit better than optimal medical therapy under certain circumstances, but still not good enough. So this is the area of devices in development to see if we can augment the effect of device-based therapy, complement its use with all of the important pharmacology to get better clinical outcomes for our patients. So heart failure is a systemic disease. It is progressive. Significant advances in medical therapies we've just discussed. But in advanced disease, there is still significant residual risk of mortality and hospitalization. There are many untapped targets, and many of the device-based strategies under development and investigation are trying to address this. Some of these are invasive, and many of them are deployed using percutaneous or transcatheter approaches. So this brings us to the integration of heart failure specialists and interventionalists, and we now whimsically call this interventional heart failure. We are trying to see how we can work with our heart failure colleagues to improve patient outcomes in heart failure. Okay, let me go on to some specific case examples. We're going to start with cardiogenic shock. This is the problem with cardiogenic shock. There have been a lot of randomized controlled trials. They're very difficult to do, and the outcomes have been almost uniformly have been completely unfavorable. There's been some interest and excitement with the percutaneous microaxial flow pump device, the so-called Impella, in a variety of settings, even in the role of AMI cardiogenic shock, as shown here. But I will tell you, even though it's gaining popularity, support for the benefits of therapy have not been very clear, and there's growing concern regarding complication rates. But I will say that recently at the ACC meeting, there was the results of the DanGer trial that was done outside of the United States, and it was a randomized trial looking at a percutaneous microaxial flow pump, the Impella, in infarct-related cardiogenic shock. It's a very important clinical trial, so it's randomized 1-to-1 in patients that have cardiogenic shock, acute MI, LV failure, where a combination of a flow pump, the Impella device, and PCI was performed versus PCI alone, with the allowance of escalation therapy as indicated, with a primary endpoint of all-cause mortality at 180 days. Over 350 patients were randomized. These were your typical patients, very sick, median LVEF 25%, largely LAD or multivessel disease, and Sky Class C, D, or E shock. So clearly, this is a sick population of patients. The inclusion criteria well understood, very few exclusion criteria. The primary endpoint showed a significant benefit of mortality at 180 days that was consistent across all of the pre-specified subgroups. This was a very important result, but at the expense of more adverse events, including bleeding, limb ischemia, renal replacement therapy, a little bit on the stroke side, and certainly an increase in hospital days. So we're learning, but at least now we have something to indicate that we can treat some of our patients with cardiogenic shock with the opportunity of some clinical benefit. So the routine use of a microaxial flow pump on top of standard care reduced death from any cause in patients with STEMI and cardiogenic shock in the DanGer trial, was associated with an increased risk of adverse events. We can't extrapolate this to other causes of cardiogenic shock, and certainly to non-ischemic cardiogenic shock, but this is a beginning, and certainly a very exciting beginning for us in cardiogenic shock. An area of great controversy has been the use of interatrial shunt devices. This is a slide that shows you 7 intraatrial shunt devices that are used to decompress left atrial hypertension, and of these 7, 4 of them are in patients that have heart failure and preserved ejection fraction. The 2 most commonly used have been Corvia and V-Wave, and Occlutech is also available in Europe. The others are investigational. We've been working a lot with the Corvia atrial shunt device. And again, this is a night null cage. It's an 8 millimeter shunt diameter, which results in a QP-QS ratio of about 1.2 to 1.3 to 1, remains patent over time, so it doesn't close over time. And it allows dynamic decompression of left atrial hypertension. We did an initial sham-controlled randomized trial in 44 patients with hemodynamics and exercise supine bicycle hemodynamics to indicate that by putting this device in, we see a separation and we see reduced pulmonary capillary wedge pressures during exercise with this shunt device, which gave us a mechanistic justification for doing a pivotal clinical trial, which was called the Reduce LAP2 study in 626 patients. This was sham-controlled, and the outcome was negative. We saw no benefit overall. This, of course, was a little discouraging, and we looked at the key endpoints. We looked at death, we looked at CVA, we looked at the cumulative incidence of heart failure events, but we saw no difference. However, when we looked more carefully at a pre-specified post hoc subgroup, we saw that there were generally two populations of patients, and about half the patients that were randomized fell into what we call a responder subgroup. Those patients who did not have marked elevation in pulmonary vascular resistance with peak exercise, and those that did not have pacemakers or ICDs. And after 12 months, you could see in those patients that were in this responder group, there appeared to be a reduction in heart failure events, an improvement in KCCQ scores. So we felt that maybe if we screened the patients more carefully, in other words, if we were more specific about the phenotype of HFpEF, maybe we would have an important therapy. So these are the 2-year outcomes from that same study, and now these curves are beginning to separate even more. A 50% reduction in heart failure events, as opposed to a 200% increase in those patients that were in the so-called non-responders. So we think that we're beginning to understand more about the response to HFpEF. We think that when the LV and LA gets smaller, when you decompress with a shunt, you need to avoid things like hypertrophic cardiomyopathy and low output states. The RV and RA are going to get bigger, so you need to avoid vulnerable patients that have RV failure. The tricuspid annulus is going to dilate a little bit, so you need to avoid moderate or greater TR in the patients. And the blood needs to get back to the left heart, so you've got to avoid latent pulmonary vascular disease. Now at the ACC, that same ACC, there was another study using another one of these interatrial shunt devices in a study called Relieve HF. And this was both in HFpEF and HFrEF. Now for the overall population of about 500 patients, again, out to 24 months, there was no benefit overall. And in the individual events that were looked at, there was no benefit overall. And there was no change in the KCCQ scores over time. But when you divided the populations between those patients with true HFrEF, EF less than 40, and patients with EF greater than 40, the results were totally different. And in the patients that had reduced ejection fraction, there seemed to be benefit. Those with preserved ejection fraction, there seemed to be worsening. So it was very interesting that there was, again, a responder and non-responder population. Now, I will say the preserved EF patients in this trial were much, much sicker than the studies that were enrolled in the Reduce LAP2 trial. Interestingly, irrespective of the improvement in heart outcomes, there was not much change in KCCQ scores. And again, this is a sham-controlled study. So, are shunts harmful in all HFpEF patients? Frankly, we think the two studies indicate the same thing, that in reduced LAP non-responders, they responded like the Relieve HF group of HFpEF patients. So this to us was concordant. We think that phenotype matters, and if you really identify the correct phenotype of HFpEF patient, that there may be some role for treating patients using an interatrial shunt device in the difficult to manage HFpEF patients. And we're now in the middle of a responder HF trial, which is to prospectively confirm that observation and that hypothesis to see if we can demonstrate, using careful physiology, careful patient screening, the responder group, and demonstrate in a sham-controlled study clinical benefit, and that's ongoing. Now, an area of great interest has been remote monitoring strategies. Now, this is not so much a single device, but a concept. And the concept is that the patient becomes part of the therapy. The patient gets trained in the use of new technologies, data gets developed, it gets uploaded to the cloud, it then gets analyzed by not just physicians, but physician surrogates and data scientists. Then there's a delegation of decision-making that goes back to the patient to adjust therapy, and all this is done out of hospital and remotely, because the numbers of heart failure patients are too difficult to manage unless we have a much more facilitated and efficient process. Now, some of the early work done with ambulatory hemodynamic monitoring demonstrated very clearly in 3 clinical trials, Champion, Guide HF, and Monitor HF, a very consistent effect, regardless of the EF category, or those with prior heart failure hospitalizations, a very significant reduction in heart failure hospitalizations using implanted ambulatory hemodynamic monitoring devices like the CardioMEMS device. In fact, if you pool several of these studies, you not only see a change in hospitalizations, but actually a mortality benefit over time. This is with invasive hemodynamic monitoring with an implanted device which gets interrogated. Remote monitoring options in heart failure are expanding. The most easy ones are the patient-collected data. Weights, vital signs, there are new things with voice patterns and lung water. A host of new wearable devices, multi-parameter sensing via a lot of the CRM devices that are already implanted, and then what I just mentioned, the implantable hemodynamic monitors. So there are multiple categories of new monitoring devices. The CIED-based multi-parameter monitoring devices have now already been demonstrated to anticipate heart failure events. So we're beginning to get the indication that this class of device may be very helpful in anticipating events. The wearables certainly give us a great deal of information, but the kind of information, heart rate, respirations, impedance, activity, may not be clinically useful by itself, but now some advanced application of machine learning analytics is being used, and we do think it may provide actionable indicators for impending heart failure decompensation. So now this concept of sensor-aided heart failure management is becoming more of a reality to people. The real-time data from patients are utilized to generate a personalized baseline. Deviations from baseline trigger clinical notification, and then clinicians review the individualized data to direct intervention. There are many challenges that lay ahead, and I'm not going to go through all of them. Personnel, cost, equity, workflows, algorithms to respond to these deviations. So this is still a work in progress, but it's very exciting. It would not be exciting enough if it was just a matter of, are we going to be able to change the diuretic dose a little bit? We've got to be able to facilitate GDMT, and these are some studies to indicate already that they've been able to demonstrate that you can facilitate the correct and accelerated pathway to achieving GDMT. At New York Presbyterian Hospital, we've now enrolled 1,600 patients in a centralized heart failure monitoring program. So this is remote patient monitoring, and it's a very diverse population. And it uses a variety of different devices, implantables and non-implantables. So far, we've been able to demonstrate and publish a 128% increase in guideline-directed medical therapy, a 55% decrease in all-cause hospitalizations, a 77% decrease in heart failure hospitalizations, and the patients seem to love it. So we're beginning to demonstrate that we can use this in hospital systems. Remote monitoring options are expanding. Ambulatory hemodynamic monitoring is effective in reducing heart failure hospitalizations and mortality, especially in the high-risk patients. New trials will define the role of this multi-parameter monitoring using CIEDs and wearables. Machine learning and AI will be critical to help us to make all of this complex data streams into actionable alerts. There'll be standardized workflows and algorithms. The ultimate goal is to empower the patients for self-management using these tools. An area of great consistent concern for us has been acute decompensated heart failure. And we've worked hard to understand how we can categorize these decongestion therapies. And we've come up with an algorithm called DRIPS, and I'll show it to you in a moment. The pathophysiology of acute heart failure is well known. Elevations in CFP, wedge pressures, cardiac output and blood pressure go down. Ultimately, there's a reduction in urine output and diuretic resistance. I think all of the smart clinicians in this room understand this. So we've tried to put together a series of approaches that would help us to attack the problem and classification of decongestion therapies. And again, we use the acronym DRIPS that involves with things that increase lymphatic drainage, reduce renal venous pressure, increase renal artery pressure, selective renal artery vasodilators, venodilators, things like aquapheresis and enhanced dialysis, many different categories. And I'm going to show you just some examples because it's just too complex to go into this in great detail. So greater splanchnic nerve denervation is being used now to increase the splanchnic vascular reservoir to be able to manage or treat patients with a congestion-based heart failure. There are many devices that will remove fluid by either aquapheresis, hemofiltration, many systems that are being developed to improve that aspect. To improve the interstitial component, there are devices being developed now to reduce thoracic duct outlet pressure and to use the eccrine glands to increase sweat production in a way that will reduce volume in patients with congestive heart failure. Trying to amplify the effect of inotropes by a variety of techniques is now being used. Multiple devices are what we call pushers, which will increase renal artery pressure and flow to improve urine output and to reduce diuretic resistance. And there are now 4 that are being tested in a variety of clinical trials. And there are pullers that reduce renal vascular afterload or reduce renal venous pressure that are also being tried. And then there are selective vasodilators with catheters that go directly into the renal arteries to amplify the effect. So which patients could benefit from these therapies? Certainly decompensated heart failure, either inpatients or outpatients. Patients with persistent congestion, difficult to treat, these so-called diuretic-resistant patients. Without question, a favorable risk-benefit is based on the degree of invasiveness of these therapies and the magnitude of the treatment effect. So we always have to look at this risk-benefit ratio. And diuretic resistance comes up again and again and again. And we're now developing standardized ways of being able to define diuretic resistance and how to overcome it, which we won't get into, but it's part of all the clinical trials that are being developed now. The risk for us is the degree of invasiveness. The magnitude of benefit are to look at surrogate endpoints like change in urine output and clinical endpoints like shorter hospital stay, reduced readmission rates, and mortality. So this whole class of therapies, of decongestion therapies, is one of the hottest areas of investigation in heart failure. And finally, LV remodeling approaches we think are also very important. So LV reconstruction or reverse remodeling devices have been developed. Several of them are now being used in pivotal clinical trials. I won't go into too many of the details, but I want to mention that for a long time, more than a decade, it's been clear that therapies with evidence of reverse remodeling are associated with improved outcomes. If you can increase EF and reduce LV diastolic or systolic volumes, you will have better clinical outcomes. So to be able to, certainly HFrEF patients, to induce reverse remodeling should be a goal. We've also learned that increased wall stress drives progressive LV dilatation, and reducing wall stress should be another therapeutic target to induce reverse remodeling. So we've spent a lot of time thinking about the two processes that affect LV reverse remodeling. They are biologic and they're physical. The biologic processes are when decreased LV afterload, preload, or neurohumoral stresses are brought about by an intervention that does not itself alter the size or shape of the heart, induces beneficial changes, ultimately leading to improved LV size and function. And that's the way drugs work. That's the way CRT works. That's the way LVADs work. These are really biologic reverse remodeling therapies. Physical reverse remodeling is when the primary effect of an intervention is to alter the size, shape, or myocardial mass of the LV. This may lead directly to improved LV function or secondarily to initiate a process of biological reverse remodeling. And this follows the classic principles of Laplace's law. And we think that there is a device that is being studied, the AccuCinch device, that may fall into this category. And this is that device. It's a device that's navigated transaortic using catheters, where a combination of anchors and spacers are placed in a ring fashion along the LV free wall about 2 centimeters below the mitral annulus, so at the base of the LV basically, cinching it to form a target for acute LV reduction in size. And it has a significant effect on acutely reducing LV dimensions. Here you can see the device as it is implanted. This usually takes about an hour and a half to do, and about a 10 millimeter difference in the acute result from the standpoint of end diastolic dimensions. Following these patients out for a year with CT imaging, we saw something curious, that the degree of improvement in LV dimensions continued over time. Now, it wasn't just the acute effect, but continued over time. So we did a clinical trial. This is 51 patients that were treated in a variety of centers to see if this was a consistent observation. We found the device to be fairly safe from the standpoint of important complications. We found that the quality of life and exercise capacity, as measured by standard indices, improved certainly initially from the direct effects, but continued to improve for several months thereafter. The ejection fraction didn't change initially, but increased. Not greatly, but increased consistently over time. But most important, the LV end diastolic volume, which did decrease somewhat in the first month due to the device itself, continued to increase over time. So the initial physical remodeling initiated a biologic reverse remodeling, which we think is an important observation. And this is all core lab echo confirmed. So now we're in the middle of a pivotal trial. We've enrolled about a third of the patients that need to be enrolled in this important study, looking at both clinical endpoints and hard endpoints and surrogate endpoints as well, that will give us a better understanding of whether or not we actually have a device that can cause LV remodeling in HFrEF in those patients that with guideline-directed medical therapy are still importantly symptomatic. So to conclude, this is the vicious cycle of heart failure. This is a complex diagram, and all of these new therapies that we're discussing are targeted to specific hemodynamic or anatomic substrates. So over time, we're beginning to understand how we can influence heart failure from many different perspectives. And this is the basis of what we're trying to do with interventional heart failure. Now, if you're a physician in the audience and you say, well, how do I get involved in this? Certainly, anyone who really wants to be at the center of it has to understand clinical heart failure, understand pharmacology, and be very good at understanding hemodynamics. There are many different directions that you can come from. Many of the people in critical care medicine are now becoming experts in heart failure. Certainly, cardiac imaging is another place where we're gaining a lot of expertise to be able to base heart failure therapies. From the mechanical circulatory support and shock side, that's another way to be able to approach this. And finally, if you're an interventional cardiologist interested in heart failure, whether it's coronary intervention, advanced coronary intervention, or structural intervention, you certainly can participate in the activities of understanding how to begin using medtech as a complement to pharmacology to ultimately improve therapy in these complex, advanced, late class 3, early class 4 heart failure patients. So I would encourage you to become interested in this. And then I would also invite you again to attend our next version of TCT, where Dan Burkhoff and others will really promote the idea of trying to understand how transcatheter heart failure therapies can complement pharmacology to manage these most difficult patients. Thank you very much.